Now I want to talk about the different training programs. The next two slides highlight two different models which can be implemented in BC and that meet provincial and federal guidelines. The first is the individual training that I'll show on this slide. The next slide I'll show the group training model. The model chosen will depend on the characteristics of the naloxone site participating. Some sites provide both types of training. In this first circumstance, we have identified a take-home naloxone site. In this example, I'll pretend it's a community health clinic. This site has identified educators, a prescriber, and the BC CDC has already sent naloxone kits to the dispensary. The site either identifies clients or clients request that they take part in the program. Now, kits can only be prescribed to someone who is indicated to be at risk of an opiate overdose. However, we do encourage sites to also train family and friends, as it is likely another person would need to administer naloxone in an emergency situation. Once the individual is trained, the educator may provide them with a training certificate that's available on our website. Note, training usually takes at least 20 minutes in an individual session in order to cover overdose prevention, recognition, and response information, including how to administer naloxone. Now, some sites use a certificate, while others just record who has been trained. After the individual has been trained, they make an appointment to see a prescriber. If the prescriber feels this person understands the training and has an indication for naloxone, they receive a prescription. At this point, the individual is dispensed a kit from the participating site. The sites will have to send the BC CDC their prescriptions, the training form, as well as a dispensing record. If a client uses the naloxone kit, they are encouraged to return to the site to receive another kit. They would follow the same process, but before receiving another kit, we encourage them to work with a service provider and fill out the administration form. This is to help the client debrief on their experience and also ways to improve in an emergency situation as to how to respond. Now I'm going to discuss briefly the group training programs. Other sites utilize group trainings. This usually occurs in the service organization. These groups usually range from 6 to 10 people, but we wouldn't recommend more than that, just to ensure that everybody receives all the attention and gets all the information they need. So clients and family and friends come to the organization at a set time and learn together. We have developed pre- and post-tests for these groups training sessions that can be found on our webpage. At the session, aside from the educator, the prescriber also attends. This way, a prescriber is ensured that clients have completed the training and can also set aside a few minutes to consult one-on-one with the client at the end of the session. If the prescriber feels that all criteria are met, they can write a prescription at the session and dispense a kit for the client at the site. Now we have provided the background to how the program came to be and how it was developed. Now we will review the successes and challenges of the program in the first 9 months since it was implemented. As of April 2013, we have 18 take-home naloxone sites taking part. 10 are located in the Vancouver area, 5 in the interior region, and 3 are located on Vancouver Island. In our previous slides, we saw that there are quite a few sites that have joined the program, but I just want to emphasize that although we launched the program in August of 2012, and lots of sites were anticipating its launch, it did take time for sites to consult with the community and also figure out ways that the program can be implemented in their organization. And I do encourage sites to take that extra time and make sure that the community is engaged and that the program will be sustainable. We also noted that the health authorities, with very supportive medical health officers, have been most successful in implementing take-home naloxone programs. To date, we have had 995 kits sent to the 18 participating sites. We've had 248 clients trained and prescribed naloxone. We also have had 14 overdose reversals to date. There are a few lessons learned when implementing the BC Take Home Naloxone program. For one, we learned that we need to follow up with their sites, as our sites need reminders to send in all the required forms to meet BC and Health Canada regulation. These forms are also very important as they do help with our program evaluation, and I'm able to present to you all the numbers that I've just done for our 9-month follow-up. We also note that although we had a web page with all the information that sites would need to implement the program, we know that people like to talk to people. So it's important to also have somebody available to answer any questions that organizers have at sites. Now I'm going to pass it on to Jane, as she is going to review some of the qualitative evaluation piece that we have done for the program up to date.
So this is, we felt it was important to evaluate as we were implementing the program so that we could identify issues and shortcomings as we went along rather than waiting until we've been in process for a year. We therefore have performed some focus groups and some interviews with key stakeholders. We have interviewed about 20 individual clients and had 3 focus groups. We also have interviewed parents of people who use opioids and the police and service providers. It was interesting when we interviewed the police that there was obviously a misperception about how naloxone worked, despite the fact we'd met with various inspectors and others within the police force. So after that we created a one-pager which can be found on our website, which has been distributed to the police. So for the clients, focus groups and interviews, the clients who took part in the program felt empowered and felt valued. As I mentioned, there were kits confiscated by the police, and our interviews with the police showed us that we needed to do further education there. The training was sometimes brief and not complete. When we asked clients how long it took and what they'd taken away from it. So we need to make sure that they have the full overdose prevention and recognition training as well as how to administer the naloxone. One client said, "I think it should be offered to the community anyway, because you never know where it will happen, and it's so easy to save someone's life that way, right?" Parents of those who used opioids, this was really fairly, the comments were quite emotional. One parent said, "I would certainly want to promote it to other parents," and another mentioned that it was a primary concern is that the child will die using opioids. So if there's a way that something could save her, it would be beneficial. As I said with the police, there were some that were not aware despite our attempts. This, we hope, has now been addressed. So some lessons learned from early on is that implementing the program is a true collaborative effort, and engagement is key to get everybody on board to start with. You need a team of committed people to support each other when finding obstacles and also to help celebrate successes together. Healthcare and service providers are generally very supportive, and often their main concern was regarding the time it would take. We also found stigma was a huge issue, and training people who use drugs to respond to overdoses requires trust and a paradigm shift within the healthcare society. The program was slow to start, but has taken off fairly rapidly now. We also note that administration forms are not being returned or not being completed. We recently created a short interview video which shows the forms and gives the rationale as to why this is important, which can be found on our website. We also need to ensure proper training of all clients at the sites. We also have to we can't make assumptions about communication, and multiple engagement with police is necessary to ensure kits are not confiscated. So in final summary, the program is definitely needed. It is empowering for all, and the enthusiasm of the service providers and their willingness to be involved and to go the extra distance can make it happen. We'd like to acknowledge many partners and people with whom we consulted, and especially the sites that are now taking part in the Take Home Naloxone program in BC, our Community Advisory Board, and those who helped and consulted with us, and also people at the BC Centre for Disease Control who supported this program, especially Erin Gibson and students Dylan Collins and Christy Williams. And Justine has mentioned our Heart Toward the Heart program and the website, and there is a contact information outreach at towardtheheart.com for questions. Thank you.
Thank you.
And thank you, Dr. Buxton and Despina, for a review of your program. That's tremendous, and I have had a look at your Towards the Heart website, and it is chock full of information, so thank you for highlighting some of the topics and resources that are available there. You had talked a lot about stakeholder engagement and the importance of that, and the fact that it needs to be ongoing to be successful. Can you just give some examples of how you've been connecting with police services and ensuring that they're aware of the program, and how is that going?
Well, obviously, because this is a provincial program, the actual communication often has to be done at the local level. So, as Despina mentioned, where we have very enthusiastic medical health officers and nurses, they are engaging with the local resources, the local clinics, and the local police. We in Vancouver, obviously, the program, we're here, and we find it much easier to engage and talk to people. But what we're finding is that word of mouth is actually getting out, and people are coming to us with their questions, and we're garnering more and more support from different directions.
Thank you. All right. Well, on behalf of everybody here at Eyes Wide Open, we thank you for your expertise and time taken today to tell us about your program, and we wish you continued success. All the best, everyone. We're going to sign off now. Thank you so much.